It was supposed to be 15 minutes, but I'll try to save some time and agree to do it in 10 minutes, and probably I'll try to end it even before that. And shorter DAPT therapy, as we know, initially we used to give for 1 year, then it became 6 months, 3 months. Now people are telling to 1 month. We'll try to see how we are moving from DAPT, stop DAPT 1 to light, how we are becoming more wiser. Historical perspective of evolution of this DAPT guidelines and how short DAPT is doing good to these patients, and how we need to balance risk benefit, especially in high bleeding risk patients. And so we'll review some of the clinical literature which is available, and briefly in the end, we'll conclude, say, with some take-home message. I won't take you to go through all the details of it, but it is here in 1996, dual antiplatelet therapy came into picture. And then the era of death started, cipher, so it became very, very important. And antiplatelet therapy, we all know, played a significant role in improving the results of the death stents. Started with bare metal, that was in the anticoagulation era. Then the ciphers came, then dual antiplatelet therapy came. And before not giving proper dual antiplatelet, there was a lot of criticism on cipher and taxes. Then in this era, they have proved better. And now we have better quality P2Y2 receptor antagonistic rosiglitazone come. That's where the thought process of decreasing the duration of antiplatelet therapy started. It also started with this J-cipher registry. After 6 months of continuing the drug, did not prove much beneficial, and the results were same with a very little increase in the side effects. That's how in the pre-PTCA BOBA era in 80s, DAP was not used at all routinely. Then BMS era, we used to give only 1 month dual antiplatelet therapy. Then with cipher and taxes, because of polymers and whatever reasons, then the more attention was given to antiplatelet therapy, because we did see some stent thrombosis happening even after stopping a little later. But the current generation of stents with improved stent design platform and thinner struts and better polymers, even a shorter duration of DAPT could do well to these patients. I won't go into details of all this, but it suffices to say that the patient had a stable ischemic heart disease. Probably now the guidelines say that probably 6 months could be good enough. And then if a patient has high bleeding risk, probably you would end up at 3 months. But if a patient has acute coronary syndrome, because that itself warrants 12 months therapy, but now it is trying to decrease it to half, 6 months, and then probably patient has high bleeding risk to go on to 3 months. And that's very important to see what has helped us in it. Basically, not only the increased potency of antiplatelet drugs, the advances in stent design, and then probably the awareness of technology showing that stents get endothelialized. Most of the things, 90% happens in 1 month with OCT studies. Now we became more confident to decrease this dual antiplatelet very short. And we are also aware now of that we started doing more high risk, high bleeding risk patients. And that's how we need to balance ischemia versus bleeding. We're trying to decrease the duration of antiplatelet therapy. And as we recapitulate, we had a talk on HBR yesterday. Not only age, comorbid pathologies, anemia, CKD, and many of the requirements of oral anticoagulation such patients all stand a high risk. And when you're treating such patients, probably obviously you can't give a longer duration of therapy, because bleeding once happens, it causes more problems to these patients. And this DAPT scores and the ischemic scores tell us to assess the ischemia versus bleeding risk in these patients. And then that's how the FDA and others went down in these concepts. So dualing, just to take you through this evolving of DAPT, initially Stop DAPT trial was done with the Exines platform with 3 months of antiplatelet. Then DAPT2 came with other Stop DAPT, which came with initially was done with Exines platform for the 3 months of therapy. Then after which only aspirin was given, patients did well. And DAPT2 said any type of cobalt chromium elution stents could be used. And initial ones given for 1 month and followed by randomized to clopidogrel and versus dual antiplatelet again for 12 years. And the results were good. And it also helped us to analyze and see that the bleeding endpoints decreased in this patient. So ischemia was not increased, but bleeding decreased. That's how patients benefited. Leaders-free trial compared biofreedom stent with a lesser bioabsorbable polymer with bare metal stents. Again showed that shorter duration of therapy is good enough. And Medtronic came with Onyx One stent platform where they compared with biofreedom and again showed that these patients when put on a short DAPT also did well with less of problems. The same thing when for US FDA, they did Onyx One clear study with that design was compared with the standard US FDA Zines platforms which are done before. The baseline characteristics, even higher complex cases were included. Each of them had 1.6 types of criteria, bleeding criteria, and most of the patients were, as shown here, very few were only on dual antiplatelet. Most of them were on single antiplatelet drugs. And surprisingly, it also showed that single antiplatelet, we are very comfortable using ticagrelor or prasugrel. But here, 57% of them were only on aspirin. Still, the patients did well. And the depth analysis, subacute thrombosis, TLRs are all significantly not much different in both the groups. That's how they said. On the other hand, bleeding was less and said that Onyx clearly shows that bleeding will be decreased with no increase in ischemic events and follow-up. Same thing also happened in this short DAPT study where it is comparing with P2Y2 inhibitors alone versus a combination therapy, obviously after first 1 month of dual antiplatelet therapy. Zines also did this Zines 90 and Zines 28, stretching it too much. Zines 90 was again using a 90 days dual antiplatelet therapy. Zines 28 is 28 days dual antiplatelet therapy to show that ischemia doesn't increase, but bleeding decreases. That was the Zines short DAPT program thought process. And it was studied in multiple sites and high bleeding risk patients as shown was included. Acute MIs were excluded and this severe dysfunction was excluded. Then these patients were put on dual antiplatelet short duration followed by aspirin alone, longer duration. And this study showed that this large subgroup of patients, both in Zines 28 and 90, shorter duration of DOPT, and then patients did all right. So if you see this, significant number of patients had more significant baseline bleeding characteristics. Even the higher age group patients and high-risk patient subsets were also included. Then complex lesions, multivessel disease were also part of it. Still, in spite of these complicated patients being taken, single antiplatelet drugs therapy was enough after 1 month of dual antiplatelet therapy. That's how this study concluded that all-cause death MI was same with decreased higher BARC2 and 5 bleeding. This was compared with the traditional Zines platforms of which was studied in US before and then showed that the bleedings were less and both on 28 and 90. And then on the other hand, if they try to see the BARC3 and 5 bleeding significantly less, ischemia didn't increase, but bleedings decreased. And stent thrombosis also did not increase further because of early endothelialization of these platforms. So this study, both Zines 28 and 90 concluded that dual antiplatelet therapy for 1 month is okay, especially in high bleeding risk patients. TULITE is again a study which is conducted with ticagrelor, monotherapy versus ticagrelor with aspirin. Again, showed that this also worked. That's how we became more confident that 1 month DAPT is also okay, especially when you're using the latest generations type of stents. It's not the same for all the stents, but probably these two stents which have tested, we can take this as equivalent. We always need to weigh the ischemic risk versus bleeding risk in a patient and patients who have a high ischemic risk, and especially in ACS type of scenarios, probably if possible, you have to continue the higher version of the antiplatelet drug and maybe give both for 1 month and give ticagrelor or prasugrel, stop aspirin. Whereas patient has more of bleeding risk, we do the opposite and then continue only the aspirin for long term. But we need to have more further studies in this DAPT duration, especially in high-risk scenarios like ACS and STEMI. And probably different drugs combinations need to be studied further to get positive outcomes to these patients. And what is more important is doing the procedure right and optimizing the results with proper imaging, guidance and other things, and doing the stenting right becomes very important. Thank you very much. I hope I finished in time. And I bring you all your attention to the ACCC 2021, where all of us are coming on platform, and request all of you to join virtually for this meeting. Thank you.
Thank you, Dr. Sreenivas Kumar. Excellent overview of recently published SHARDAP trials. And in the interest of time, we are concluding the session. I thank each and every speaker, especially Dr.